Daphne, first of all, thank you very much for your very kind introduction. And I also would like to thank the organizers of this seminar for inviting me. I love endocrinology, so when people invite me to talk about endocrinology, that's fun for me. And this evening, I will focus on primary hyperaldosteronism. And I'd like to start with a question. How many of you have ever diagnosed primary hyperaldosteronism in a cat? At least one, eh? Mike. Nobody else? Okay. At least that tells me that I've chosen the right title. A highly underdiagnosed disorder in cats, and actually also in humans. Because I'm quite certain that most of you have seen cats with primary hyperaldosteronism, but apparently you didn't recognize them. And that will be the main focus of this presentation, to show you what is the clinical picture of primary hyperaldosteronism, and that when I come back, let's say in 2-3 years, and then when you ask, have you ever seen cats with primary hyperaldosteronism, then you all say, yes, we did see them. So if you talk about primary hyperaldosteronism, then we are talking about an adrenocortical disorder. And in this slide you see a very schematic illustration of the adrenal. And you all know that the adrenal consists of an inner adrenal medulla and an outer adrenal cortex. And you also know that the adrenal cortex consists of 3 layers: an outer zona glomerulosa, a middle zona fasciculata, and an inner zona reticularis. And it's important that you know that we have these 3 layers. It's going right with the... Yeah. Okay. It's important to know that we have these 3 layers because there is a clear link between the anatomy and physiology. And if we talk about the physiology, then we talk about hormone production. And the adrenal produces a lot of different hormones. The adrenal medulla mainly produces the catecholamines, such as epinephrine, but now we'll focus on the adrenal cortex. In the adrenal cortex, 3 groups of hormones are produced. The mineralocorticoids, and you can already see it, corticoids, so hormones derived from the cortex that have an effect on the minerals. And the most important representative of that in dogs, cats, and humans is aldosterone. Then we have the glucocorticoids, again, hormones derived from the cortex that have an effect on glucose, actually have an effect on gluconeogenesis. And the main representative of that in dogs, cats, and humans is cortisol. Then there are also some androgens produced in the adrenal cortex, not very important in dogs and cats, by the way. And in this slide you see the link between the anatomy and the physiology. I already mentioned that the adrenal medulla produces the catecholamines, and then if you look at the renal cortex, then the zona glomerulosa produces aldosterone, the zona fasciculata mainly produces cortisol, and the androgens are mainly produced in the zona reticularis. So how is it possible that each layer produces its own group of hormones? Well, that's shown in this slide, and this slide may show a little bit complicated, but actually it isn't. It shows that all hormones, all adrenocortical hormones that you see depicted over here, are derived from the same precursor molecule. They're all derived from cholesterol. So cholesterol can be converted into the mineralocorticoids in aldosterone, it can be converted into cortisol, and it can be converted into the androgens. And that occurs in different steps, and each step is catalyzed by an enzyme. And if you look more specifically to this enzyme, then there's one enzyme that's very important in dogs, and that's 17-hydroxylase. If there is expression of 17-hydroxylase, then cholesterol will be converted into cortisol and into the androgens. So in the zona glomerulosa, 17-hydroxylase is not expressed, and that's the reason why cholesterol is then converted into aldosterone. There's another enzyme which is quite interesting if you look at the formation of the adrenal steroids, and that's 3-beta-hydroxysteroid dehydrogenase, depicted over here, here, and here. And this is the enzyme that we inhibit if we treat dogs with Cushing syndrome with trilostane, with veterinal. And we'll move on now to the adrenocortical disorders. And then we can distinguish functional disorders and non-functional disorders. And if we talk about non-functional adrenocortical disorders, then we mainly talk about non-functional adrenocortical tumors, the so-called incidentalomas. Also something that we see a lot in dogs and cats. In human medicine, it's known that about 10% of the population have an adrenal tumor. And in dogs, it's between 5 and 10%, and in cats, as far as we know now, it's about 5%. So also a very interesting topic. I focus now on the functional disorders, and then we have an hypofunction, adrenocortical hypofunction, for example, Addison's disease, primary hypoadrenocorticism, but we also have a secondary hypoadrenocorticism due to ACTH deficiency. If we then look at the hyperfunction, then we have 3 layers, so we also have 3 forms of adrenocortical hyperfunction. When there is a hyperfunction of the zona reticularis, then this may result in excessive secretion of androgens. It may result in hyperandrogenism, which is the main adrenocortical disorder in ferrets. When there is a hyperfunction of the zona fasciculata, it can result in hypersecretion of cortisol, so it can result in hypercorticism. Actually, that's Cushing's syndrome. And we may have a hyperfunction of the zona glomerulosa, resulting in excessive secretion of mineralocorticoids and an excessive secretion of aldosterone. So that results in hyperaldosteronism. Combined, these hyperfunctions are called hyperadrenocorticism. And quite often, veterinarians think that hyperadrenocorticism is the same as Cushing syndrome, which is not right. It's just one of them. Also, hyperaldosteronism is a form of hyperadrenocorticism. In human medicine, hyperaldosteronism, primary hyperaldosteronism, is also known as Conn's syndrome. And later on we will see that Conn's syndrome may be due to an adrenocortical tumor, but it may also be due to adrenocortical hyperplasia, quite often bilateral adrenocortical hyperplasia. And now I want to tell you a little bit more about Conn. And you may wonder, why is a veterinarian going to tell you something about human medicine, about Conn? Because he was a human doctor. Actually, he was a professor of medicine at the University of Michigan. Well, the reason for that is that there are very interesting similarities between the situation in humans and the situation in cats with regard to this disorder. Also in humans and in cats, it's a highly underdiagnosed disorder. And because of that, in most cases, it's only treated symptomatically. And in addition, both in human medicine and in feline medicine, it started with a case. And I'm going to present these cases to you. So Professor Conn did a lot of research that was devoted to the adaptations to tropical heat. So how is it possible that people survive if they are in tropical circumstances, that they don't die from dehydration? And he found that the hormone produced by the adrenal plays an important role in this protection against dehydration. And this is the hormone that we now know as aldosterone. And Professor Conn was invited to give a presentation at the annual meeting of the Central Society for Clinical Research in 1954. And then something very interesting happened. He was invited to give a key lecture about his personal philosophy on clinical investigation. But then he entered the stage, and now I'm going to quote him. "I have prepared no comprehensive review of my personal philosophy of clinical investigation. Instead, I plan to make a scientific report to you about a clinical syndrome, the investigation of which has been most exciting to me." This is interesting. And you invite me to give a presentation about primary hyperaldosteronism. And then I tell you, I had this great neurological case, and I'm going to give a presentation about neurology. You would be surprised, but that's what happened here. But I have to say, it was a very interesting case. So I'm also going to present this case to you. It was about a 34-year-old lady, and this lady had a lot of problems. Already since 7 years, she had muscle problems. So attacks of muscle spasm and muscle weakness. And since 4 years, it was known that she had arterial hypertension with a systolic blood pressure of 176 millimeters of mercury and a diastolic blood pressure of 104. And a lot of physicians had tried to find the underlying cause of these problems. So with the possibilities that they had in those days, they found that this patient had a very severe hypokalemia, and that sometimes there was also a high plasma sodium concentration. But they couldn't find what was the reason for these abnormalities. For example, they looked for Cushing's syndrome, but this lady did not have Cushing's syndrome. So actually, nobody knew what was going on in this lady. And then this patient was referred to Kohn. And he immediately thought about the hormone that he had discovered, aldosterone, because aldosterone results in reabsorption of sodium in the kidney and results in excretion of potassium. So that could explain the abnormalities in the electrolytes. So, but how to prove that he was right, that this lady had a problem with aldosterone secretion? It was 1954, so an aldosterone assay was not available. So he had to use experimental animals. So he used rats from which the adrenals had been removed. So actually rats with Addison's disease. And then he administered urine of this lady into the abdomen of these rats. And he compared that with the effect of urine of healthy people. And by that he could demonstrate that the urine of this lady had a 22 times greater mineralocorticoid effect than the urine of healthy people. And by that he could demonstrate that there were much more mineralocorticoids present in the urine of this lady. So he told this lady that she had a problem with her adrenals. And he proposed to the lady to remove the adrenals. So even nowadays, adrenalectomy, especially bilateral adrenalectomy, is quite an intensive procedure. And it certainly was in 1954. But nevertheless, the lady said, let's go for it. And it's interesting because in those days when they write publications, then they include a lot of information about the personal communication with the patients. So we know quite a lot about it. So the lady said, this is no lie for me, so let's go for it. So then something interesting happened. The surgeon opened the abdomen, so performed laparotomy, looked into the abdomen, and then he asked his assistant to call Kohn. So Kohn also entered the operating theater, also looked into the abdomen and started to scream, yes! I was right. And you can read this in the article. Interesting. And he was right because this lady had an adrenal tumor. The tumor was removed, and after removal of the adrenal tumor, actually of the adrenal with the tumor, there was almost complete disappearance of clinical signs. So this is the first well-described case of primary hyperaldosteronism in human medicine. And in human medicine it's often called aldosteronism instead of what we call it hyperaldosteronism. In the 10 years that followed, Kohn diagnosed primary hyperaldosteronism in more than 150 cases. So in only 10 years' time, in more than 150 cases. A completely unknown disorder, and he saw it very frequently. And what he saw in most of his patients was that these patients had arterial hypertension. And based on that, he hypothesized in his first article about that about 20% of the people with arterial hypertension would suffer from primary hyperaldosteronism, which would mean that it would be a very common disorder. Think about how many people have arterial hypertension. And if 20% of them would have hyperaldosteronism, that would be a lot. In a later publication, he changed this figure to 10%. Still a very common disorder. But in real life, it was diagnosed in much less than 0.1% of the cases. But it's an underdiagnosed disorder. It's there, but you have to look for it. And if you look very carefully, then you see the alligator over here. If you don't look for it, you don't see it. And that's the same with primary hyperaldosteronism. Because if you look at the recent literature, then Kohn was right. Indeed, depends a little bit on which article you read, but between 7 and 13% of the people with arterial hypertension have primary hyperaldosteronism as the underlying cause. But you have to look for it. I can tell you, in Utrecht, the veterinary faculty is very close to the human academic hospital. And there they almost never diagnose primary hyperaldosteronism. If I determine aldosterone, I do it in the human lab. But I do it more often than my colleagues from the human hospital. We have another academic hospital in the Netherlands, in the northern part of the Netherlands, in Groningen. And there, they routinely determine the aldosterone concentration in these patients. And then indeed they find that in about 10% of the cases, there is indeed primary hyperaldosteronism. So you have to look for it, otherwise you will not find it. I already mentioned that one of the reasons why I wanted to tell you this story about human medicine is because there are so interesting similarities. Also in feline medicine, it started with a case. And this cat was very famous in the Netherlands. It was used a lot in the world of advertisement. Here you see a beautiful advertisement for the musical Cats. And I think that you agree with me that this is a beautifully looking cat. And one of the reasons why this cat is looking so beautifully is that the cat has very large pupils, bilateral mydriasis. For example, you can compare it with the pupils of this cat. This cat is actually bilaterally blind. But that was not the reason that the cat was referred to my department. The cat was referred as an emergency case because the cat was not able to jump anymore, had cervical ventriflexion, so could not raise the head properly, and when the cat was able to walk, it easily fell in lateral recumbency. Now, if you look at these problems, you can combine it, and the most logical explanation then is that we are dealing with muscle weakness. And what can cause muscle weakness? What's the differential diagnosis of muscle weakness? Well, there are a lot of differential diagnoses, but the most common one is hypokalemia, a low plasma potassium concentration. So the next step in a case like this is to determine the plasma potassium concentration. And that was done in this case, and you can see that the plasma potassium concentration in this cat was very low compared to the reference range. So the cat has hyperkalemia. So what should be the next step? Well, most veterinarians will say, then we have to treat the cat with potassium. So then we solve the problem, which is completely right. That's what we have to do. But what we also have to do is to ask ourselves, what is the reason that this cat has muscle weakness due to hyperkalemia? And what are the possible explanations for hyperkalemia? Well, and a very important one is that when there is inadequate intake of food. When the cat doesn't eat for 3 days, then it can already result in hypokalemia. So this is a very common cause. Hypokalemia may also be due to a shift from potassium from the extracellular fluid into the intercellular fluid. For example, when there is alkalosis. Or when you have a cat with diabetes mellitus that you treat with insulin, then also there will be a shift from potassium from the outside of the cell to the inside of the cell. A very important reason is also loss of potassium. Loss in the gastrointestinal tract by vomiting and or diarrhea. And it may be due to excessive loss of potassium with the urine. There's always a lot of potassium in the urine, but when there is excessive loss of potassium with the urine, it may also result in hypokalemia. If we then go back to our patient, then the cat was eating completely normally. So this could not be the reason. There were no indications for a shift. The cat did not vomit, and the cat did not have diarrhea. So the most logical explanation for hypokalemia in our cat was that there was excessive loss of potassium with the urine. So what happens with potassium in the urine? Or in the kidneys, I should say. Well, in this slide you see a schematic illustration of a nephron, the functional unit of the kidney. Here we have the glomerulus, the proximal tubule, the descending limb of the loop of Henle, the ascending limb of the loop of Henle, the distal tubule, and the collecting duct. What happens with potassium? Well, potassium is very small. So all the potassium in the blood will go through the glomerulus and will appear in the primary urine. And in the proximal tubule, most of this potassium is reabsorbed again. Normally more than 90% is reabsorbed again. The remaining potassium will reach the loop of Henle, and at the end of the ascending limb of the loop of Henle, again, there are potassium transporters, so it again results in reabsorption of potassium. Actually, almost all potassium that has been filtered is reabsorbed. And this reabsorption of potassium in the first half of the nephron is a more or less automatic process. It's not very well regulated. But of course we need a very good regulation of the potassium excretion. And this regulation occurs in the second half of the nephron. And the most important hormone with regard to the regulation of potassium excretion is aldosterone. So, how can it result in hypokalemia when something goes wrong in the kidney? Well, it may be that you have a problem in the proximal tubule. And the most common reason for that is osmotic diuresis. And the most common reason for that is glucosuria, for example, because of diabetes mellitus. Then the osmotic diuresis will result in a very high flow, and then there is simply not enough time for reabsorption of potassium. So then we get hypokalemia. It may also go wrong in this part of the nephron. And in most cases that's due to the effect of medication. Think about the diuretics, the loop diuretics, for example. They are called loop diuretics because they have an effect on the loop of Henle. And it may also be due to certain antibiotics. And it can go wrong at this part of the nephron when there is too much secretion or too much effect of aldosterone at the distal tubule. Also then it results in more excretion of potassium and by that in hypokalemia. So just in words, it can be due to osmotic diuresis, it can be due to certain drugs, it can be due to too much stimulation of the aldosterone receptor, and if you think about which possibilities do we have, well, it may be due to an aldosteronoma, a tumor of the adrenal cortex. It may be due, and I come back to that later on, primary idiopathic hyperaldosteronism, that's hyperplasia of zona glomerulosa tissue. It may also be due to secondary hyperaldosteronism, and it may be due to Cushing syndrome. That's a little bit difficult, but for this you have to know that cortisol and aldosterone have the same effect on the aldosterone receptor. So the aldosterone receptor is as sensitive for aldosterone as for cortisol. But that would give enormous problems when that would happen in real life, because in your blood there is much more cortisol than aldosterone. So then the aldosterone receptor would always be stimulated by cortisol. And for that we have a protection mechanism. There is an enzyme coupled to this aldosterone receptor. And this enzyme converts cortisol into cortisone. And cortisone cannot stimulate the aldosterone receptor. But if you have hypercortisolism, Cushing syndrome, there is so much cortisol that not all the cortisol can be converted by this enzyme in cortisone. And then cortisol will stimulate the aldosterone receptor. And that's one of the reasons why in Cushing syndrome you quite often have hyperkalemia, and you can also have arterial hypertension. And another reason why you may have hyperkalemia due to a kidney problem is that it may be that something is wrong with the tubular cells, and quite often that's an inborn error. Now if you look at these possibilities in our case, then the cat did not have polydipsia, did not have glucosuria, so there was no indication for osmotic diuresis. The cat was not treated with any medication, and the cat was already quite old. So the most logical explanation for the hyperkalemia in this patient was stimulation, too much stimulation of the aldosterone receptor. Then a few words about the regulation of aldosterone. And in my country, in Utrecht, when I ask students how the regulation takes place from aldosterone, there is complete silence. And for me it's a little bit strange because it's so easy. It's a mineralocorticoid. So it has an effect on the minerals. Aldosterone has an effect on sodium and potassium. So what regulates aldosterone? Of course, sodium and potassium. That's the easy answer. And for potassium, that's quite direct. If there is too much potassium in the body, then you will have a higher plasma potassium concentration, and that directly stimulates the zona glomerulosa cells to secrete more aldosterone, and by that you get more reabsorption of potassium, and the problem is solved. And it also works the other way around. If you have hyperkalemia, and it results in less secretion of aldosterone. I'll come back to that. For sodium, it's a little bit more complicated. If there is not enough sodium in the body, then we have to look at the main function of sodium. And the main function is maintenance of the circulating volume. So if you don't have enough potassium, don't have enough sodium in the body, it results in less circulating volume. And if there is less circulating volume, that will be detected in the kidney and will result in the secretion of renin. Renin will result in more production of angiotensin 1. Angiotensin 1 will be converted into angiotensin 2, and angiotensin 2 will result in more secretion of aldosterone. And if you have more aldosterone, you get more reabsorption of sodium, and the problem is solved again. So it's a little bit more complicated, but actually it's regulation by potassium and sodium. Back to our cat. Our cat had muscle weakness, and we could prove that it was due to hypokalemia. And the most logical explanation for the hypokalemia in this cat was that there was too much stimulation of the aldosterone receptor. But this cat was also bilaterally blind. And of course, when it is possible, you want to explain all abnormalities with one disorder. So could this also be explained by what we already found for the hypokalemia? Well, if there is bilateral blindness, then the most common reason for that in cats is arterial hypertension. And arterial hypertension, the main reason for that is more circulating volume. And more circulating volume, quite often, is due to the fact that you have more circulating sodium, which attracts the water. So, what happens with sodium in the kidney? Again, our nephron. Sodium, very small, so all the sodium in the blood will appear in the primary urine. And again, most of the sodium will be reabsorbed in the proximal tubule. But in this case, you see, it's only about 65%, which is an enormous achievement. Because if you look for potassium, potassium in the blood is only 5 millimoles per liter. But sodium is 150 millimoles per liter. So if you have to reabsorb all this sodium, that's an enormous achievement. So 65% is already reabsorbed in the proximal tubule. The remaining sodium will reach the end of the loop of Henle, and then again about 30% will be reabsorbed. So still not all. And again, the reabsorption of sodium in the first half of the nephron is a more or less automatic process, not well regulated. So regulation occurs in the second part of the nephron. And again, the most important regulator for that is aldosterone. But there is another part of the nephron which is important if you talk about the reabsorption of sodium. And that's over here. Here you see that the distal tubule is very close to the glomerulus. And you know how we call this. This is called the juxtaglomerular complex. Juxta means close, you know that. And that's what we always see over here. The distal tubule is close to the glomerulus. So this is an important part of the nephron. Here you see it in more detail, distal tubule, where it is close to the glomerulus. Here we have the afferent arteriole, and here we have the efferent arteriole. And if you look in more detail to the afferent arteriole, then you see that in the wall of the afferent arteriole there are specialized cells. They are called the juxtaglomerular cells, not important. But these cells are able to determine the blood pressure in this part of the glomerulus. And when the blood pressure is low, so when there is less circulating volume, then these juxtaglomerular cells will start to secrete renin. If you then look at the distal tubule, in the juxtaglomerular complex, then we also have specialized cells in the wall of the distal tubule. And these cells are called macula densa cells, also not important, but these cells are able to sense the sodium concentration in the distal tubule. And also that may result in renin secretion. So actually, the juxtaglomerular complex, the main function of it is the secretion, production and secretion of renin. So here you see it more schematically. Here we have our nephron, here we have our juxtaglomerular complex, the distal tubule close to the glomerulus. Here we have the afferent arteriole, the efferent arteriole. So here the juxtaglomerular complex, and when there is less circulating volume, then it will result in renin secretion. Then renin will take care that angiotensinogen is converted into angiotensin 1. The circulating angiotensinogen mainly originates from the liver. That's very important, but it can be converted into angiotensin 1. And angiotensin 1 is an almost inactive hormone. But it can be converted into angiotensin 2. It can be converted by the enzyme called angiotensin converting enzyme. We know this enzyme very well from the ACE inhibitors that we use in veterinary medicine. So angiotensin 1 is converted into angiotensin 2, and angiotensin 2 is a very potent hormone. That's the most potent vasoconstrictor that we have in the body. And in addition, this angiotensin 2 can stimulate the zona glomerulosa cells to produce and secrete aldosterone. And we have seen already that aldosterone will take care that in the distal tubule there is excretion of potassium and reabsorption of sodium. And here in another slide you see the relation between this system and blood pressure. If the blood pressure falls for whatever reason, it is detected in the kidney, in the juxtaglomerular complex, will result in secretion of renin, conversion of angiotensinogen into angiotensin 1, and by ACE in angiotensin 2. And angiotensin 2 is a vasoconstrictor, so the blood pressure will rise again. And angiotensin 2 will stimulate the adrenal cortex to produce and secrete aldosterone. Aldosterone results in sodium reabsorption, and by that you get more circulating volume, and again the blood pressure rises. So a very well regulated system. Going back to our patient, the hypokalemia could be explained by too much stimulation of the aldosterone receptor, but also the bilateral blindness could be explained by too much stimulation of the aldosterone receptor if it would result in more sodium reabsorption and would result in more circulating volume, and because of that in arterial hypertension. So in a patient like this, you have to investigate the renin, angiotensin, aldosterone system. And that's what we did in this cat. And then you can see that's quite often the case. If it is the first case, then you find extreme values. You see that the aldosterone concentration in this cat was more than 12,000 compared to the reference ranges. So very, very high. Actually, since then, I've only seen one cat with a higher aldosterone concentration. You also can see that the renin is completely suppressed. So in this high aldosterone is not due to stimulation by renin. So it is primary. It's a primary hyperaldosteronism. And when you diagnose this, then the next step should be to look for the underlying cause. So then you perform diagnostic imaging, and in this cat it appeared that it was due to an adrenocortical tumor, actually an adrenocortical carcinoma that had already metastasized. That's why I said this cat was very famous in the Netherlands. And here you see the adrenal, the abnormal adrenal of this cat. Now, you cannot recognize anymore that it is an adrenal. You can even see ingrowth in a large blood vessel. And a second case, a little bit more complicated than the first one. Also a cat that was referred to our department as an emergency case. According to the owners, the cat had fallen from the refrigerator because the cat was not very stable with walking, and the cat was stumbling quite a lot. So again, if you combine this, it looks like a cat with muscle weakness. And if it is muscle weakness, then we have to look for hypokalemia. And also this cat had blindness, bilateral eye problem. So in a case like that, bilateral, we have to look for arterial hypertension. Of course, we did more physical examination in this cat. The cat also had ataxia, also that can be explained by hypokalemia, and problems with nerve conduction. The cat had anisocoria, so the pupils did not have the same size. And ophthalmological examination revealed that there was retinal detachment, which was complete in the right eye and partial in the left eye. That was the reason that there was a difference in the size of the pupils. Of course, then the next step should be to determine the blood pressure. We did it with the Doppler technique, and it appeared that the cat had a systolic arterial blood pressure of 200 millimeters of mercury. So clear that we are dealing with arterial hypertension in this cat. Of course, we also did blood work, and you can see that the cat also had a very low plasma potassium concentration. So the cat indeed had hypokalemia, which can explain the muscle weakness. What's also interesting, and I come back to that, is that the urea and creatinine concentrations are also a little bit elevated. And I will show you later on that there is a link between primary hyperaldosteronism and the occurrence of chronic kidney disease. So, again, a cat with muscle weakness due to hypokalemia. Then the next step is to determine why does this cat has hypokalemia. Also, this cat was eating completely normally. There were no indications for a shift of potassium from extracellular to intercellular. The cat did not vomit and did not have diarrhea. So the hypokalemia had to be due to too much excretion of potassium with the urine. The cat did not have osmotic diuresis, did not have polydipsia. The cat did not receive any medication. It was already quite old cat. So also in this cat, it made sense that there was something wrong with the stimulation of the aldosterone receptor. And especially because the cat also had arterial hypertension. So also in this cat, we investigated the renin, angiotensin, aldosterone system. But if you look now at the plasma aldosterone concentration, then you see that the plasma aldosterone concentration in this cat is beautifully within the reference range. And if you are not an endocrinologist, you would immediately say, oh, this is normal. But endocrinologists never believe that something is normal. Mike, am I right? No. We always try to find a reason that it can still be abnormal. And that's also logical, because in endocrinology you also always have to look for the whole system. And let's look at the regulatory factors for aldosterone. Earlier we saw that the plasma potassium concentration is very important for the regulation of aldosterone secretion. And we have a hypokalemia. So in a healthy individual, hypokalemia should result in a low aldosterone concentration, so it should not be normal. The second regulatory factor is sodium, but in this case it's renin. Renin is low. And if renin is low, also aldosterone should be low. So the fact that aldosterone is not low means that it is inappropriately normal. So it's inappropriately high actually. In human medicine they have the same problem, that quite often the aldosterone can be within the reference range but still is abnormal. And in human medicine they have a solution for that. They determine the aldosterone-renin ratio. So they just divide aldosterone by renin. And we also can do that in cats, and then it results in this reference interval. And if you do that, then you see that it's elevated. And then we know that we are dealing with primary hyperaldosteronism. Also here, the next step should then be to determine what is the reason of primary hyperaldosteronism. So we do diagnostic imaging. And in this case it was not due to tumor, so it was due to hyperplasia, hyperplasia of zona glomerulosa tissue. In this slide you see the results of the aldosterone measurement and the renin measurement and the ratio in the first 11 cats in which we diagnosed this bilateral hyperplasia. In blue you see the reference range, and the red dots are the plasma aldosterone concentrations. And you see that in a few cats the aldosterone concentration was clearly elevated, but in most cats the aldosterone concentration was within the reference range. If you look at renin, then you see that also a few cats had the renin concentration within the reference range, and in a few cats it was below the reference range. But if you determine the ratio, just divide aldosterone by renin, then you see that in all cats, in all 11 cats, it was above the reference range. So this is the most ideal way to diagnose primary hyperaldosteronism. So what's going on in these cats? Well, in this slide you see part of the adrenal of a healthy cat, and this histological section has been immunostained with NSE, neuron-specific annulase, not important, but by that you can show the zona glomerulosa cells and you can show the adrenal medulla cells. So here we see the capsula, here we see the zona glomerulosa, here you see the zona fasciculata, and here you see the zona reticularis, and here you see the adrenal medulla in a healthy cat. And this is what you can find in such a cat with bilateral hyperplasia. You see there's an enormous hyperplasia of zona glomerulosa cells. And here again we have the medulla, And these are all zona glomerulosa cells. So you can, I think, understand that if you have so many zona glomerulosa cells, that it may result in hyperaldosteronism. But it also tells us that it's not easy to demonstrate this. Because if you look at the thickness of the adrenal cortex in this healthy cat, that's the same as in this cat with hyperaldosteronism. So if you perform diagnostic imaging, it may very well be that adrenals look completely normal. So you can only find it by histology. Okay, then in summary, we have hyperaldosteronism, too much aldosterone. So it results in too much potassium excretion, so it results in hypokalemia, and it results in too much sodium reabsorption, and because of that more circulating volume, and because of that in arterial hypertension. So if you have a cat with hypokalemia and or arterial hypertension, you should think about this disorder. However, in real life it's a little bit more complicated because not all cats with hyperaldosteronism do have hypokalemia or do have arterial hypertension. This is from a literature review in which we had about 50 cases with proven primary hyperaldosteronism. And you can see that from these cases, about 90% had hypokalemia. So 10% of the cats with primary hyperaldosteronism had a normal plasma potassium concentration. So sometimes you have to repeat the measurement. If they had hypokalemia, then about 2/3 of them had muscle weakness as a clinical sign reported by the owner. So muscle weakness is not always something that's reported in such a case. If you then look at arterial hypertension, then you see that about 75% of these cats with proven primary hyperaldosteronism had arterial hypertension. And if they have arterial hypertension, about 2/3 of them has changes, target organ damage due to arterial hypertension. And I will show you later on that we in cats mainly see that in the eye. But it's not only that we see effects of high aldosterone, especially in those cats that have hyperplasia. There is another reason why we especially see arterial hypertension. If you have an adrenal tumor that secretes a lot of aldosterone, then because of that, the renin will be completely suppressed. But if there is hyperplasia, then the aldosterone may not be that high, so that still the renin-angiotensin system is not completely suppressed, so that there is still some angiotensin II. And especially if you have the combination of high aldosterone and still some angiotensin II, we see other effects. For example, that we see more severe arterial hypertension. And because I already mentioned, angiotensin II is a very potent vasoconstrictor. And this combination may result in so-called pro-inflammatory, pro-fibrotic effects and microangiopathies. And in human medicine, you see that in the heart. So quite a lot of people with this disorder have problems with the heart and the blood vessels. And in the brain. And in cats, you mainly see it in the kidneys. So we did a study in which we looked at cats with chronic kidney disease. And in those cats, we looked at the renin-angiotensin-aldosterone system. So actually, we determined the aldosterone concentration and we determined the renin activity. And in those 53 cats, in 8 of them, the aldosterone-renin ratio was elevated. So indicating that we are dealing with primary hyperaldosteronism. And in 5 of these cats, both renin and aldosterone were high. So it pointed to secondary hyperaldosteronism. Taken together, it means that in 25% of the cats with chronic kidney disease, something was wrong with the renin-angiotensin-aldosterone system, which is interesting information. Because if we diagnose chronic kidney disease in a cat, then we have to tell the owner what we're going to do with the cat. And actually, we don't have a treatment. Yeah, okay, if we give a kidney diet, then that doesn't help. At least not for stopping the progression. So we don't have a treatment. But if we know that there is hyperaldosteronism, then we may have possibilities to treat these cats. So I think it's important to look for this system. I already mentioned the main changes in cats with primary hyperaldosteronism are hypokalemia and hypertension. Hypokalemia results in muscular weakness, and this can show as cervical ventroflexia, areflexic paresis, ataxia, and an inability to jump and walk. Just a few pictures. I like this picture a lot. And you see that there is muscle weakness, and you also see that the cat has very large pupils. So probably this cat also has arterial hypertension. Another one that I've stolen from the internet, but so beautifully shows the muscle weakness. In a cat like this, you have to check for hypokalemia, and maybe you also have to check for primary hyperaldosteronism. And then the hypertension. You mainly see the effects of arterial hypertension in a cat in the eyes. A few examples of that. It's not easy to see, but you see that there is some bleeding over here and here, so some bleeding in the uvea due to arterial hypertension. It may also result in bleeding in the anterior chamber of the eye. It may also result in partial retinal detachment, shown over here and here. Or it may result in bleeding in the retina. You can see that over here and over here. Or it may result in complete retinal detachment. So if there is arterial hypertension, you always have to check the eyes very carefully. Or the other way around, if you do your ophthalmological examination and you see abnormalities, then you have to check the blood pressure. And if the blood pressure is elevated, think about the possibility that we are dealing with primary hyperaldosteronism. So it's important to measure the blood pressure, and you can of course do that best by using the guidelines from the ACFIM for this. So, if you have a cat that we suspect of having primary hyperaldosteronism, the best would be to determine the plasma aldosterone concentration. If possible, also determine renin, and usually we determine the plasma renin activity. Then we calculate the ratio, and when it is elevated, we have our diagnosis, and then the next step should be to perform diagnostic imaging. And the main reason for that is to see if we are dealing with a tumor or that we are dealing with hyperplasia. If it is a tumor, then the best option would be to perform adrenalectomy. If it is hyperplasia, then it's often bilateral, and then we have to use medical treatment. So let's say a few words about the treatment. I already mentioned it can be done surgically, it can be done medically. And what are our goals? Well, we want to correct the hypokalemia, and we want to correct the arterial hypertension, and of course we also want to treat the underlying abnormality, but then we have to look for it. With respect to the hypokalemia, well, then we have to administer potassium. There are different ways to do it, but you can do it by giving a lot of fruit. In fruit there is a lot of potassium. For example, in a banana, 3.5 milligram per gram of banana. If a cat wants to eat that, wants to eat tomatoes, that may be a way to get more intake of potassium. If not, then you have to give it as potassium itself. You can do that intravenously by giving potassium chloride, or you can give it orally by giving potassium gluconate or potassium chloride. And how much should you give? Well, they have a formula for that. 4.3 minus the plasma potassium concentration of the cat. You multiply that by 0.6 and you multiply that by the body weight, and then you know how many millimoles of potassium you should give that day. If you give it intravenously, you should never give more than half a millimole per kilogram body weight per hour. Then, with regard to the arterial hypertension, if we have to treat that, the best way is to give a calcium antagonist, calcium blocker, and we prefer to give amlodipine, and we start with a dose of 0.1 milligram per kilogram body weight once daily. And in some cases that's not enough, and then you have to add a beta blocker, so then we add atenolol with this starting dosage. I already mentioned that if it is an adrenal tumor that has not metastasized and it's unilateral, and then the best way to treat such a patient is to remove the tumor surgically. But that means that you need good imaging before you start with the surgery. If it is bilateral, if it is hyperplasia, or if it is metastasized already, then of course surgery is not a good option. Then the best treatment is a medical treatment. And then we give an aldosterone antagonist, and we treat with spironolactone, which is a partial antagonist. So it means that you have to find what is the right doses in this cat. And our starting dose is giving twice daily 2 milligram per kilogram. Then going back to my title slide, in which I mentioned that it was an underdiagnosed disorder. And what's the reason that it's underdiagnosed, not only in veterinary medicine, but also in human medicine? Well, that's because it's considered rare by many veterinarians. Probably also thought before this lecture that it was a very rare disorder. It isn't. And veterinarians are unfamiliar with the disorder. Yeah, if you don't know the disorder, you will never diagnose it. But that's not true for you anymore. You know now this disorder exists. So you can never say, I cannot diagnose because I didn't know the disorder. You know it now. What also doesn't help is that in a lot of veterinary clinics, the blood pressure is not measured. That's a really good investment if you have a practice for companion animals. Invest in a blood pressure machine. There are a lot of middle-aged and older cats that have high blood pressure. So this is really a good investment. And what also doesn't help is that if there is hypokalemia and or arterial hypertension, then the patients are treated symptomatically. That's also in human medicine. Think about what happens if you have arterial hypertension and you go to your physician, to a human doctor. What will your human doctor tell you? First of all, they will tell you that you have to change the way you live. You have to be more healthy. Start sporting, which is strange advice, by the way, but it doesn't matter. You should stop smoking, drinking less. And if that doesn't work, then you get medication. Probably an ACE inhibitor. And if that tablet doesn't work, then you get 2 of those tablets. And if that doesn't work, you get 3 tablets. And if that doesn't work, then you get a diuretic. They don't think about the possibility that it can be primary hyperaldosteronism. That's human medicine. But then we, veterinarians, we do it of course much better. If we have a patient with arterial hypertension, what do? We treat the cat with amlodipine without looking for this system until today. And the same with hypokalemia. And also interesting, I told you something about chronic kidney disease. What do we know from cats with chronic kidney disease? Well, we know it can result in hypokalemia. Why? Well, maybe because they also have hyperaldosteronism. And those cats with chronic kidney disease, we know very well that they quite often have a high arterial blood pressure. Why? Well, we don't know, but we treat it. But it may be due to hyperaldosteronism. So we have to look for it. It's an underdiagnosed disorder. It's there, but you have to look for it. And if you look very carefully, you see the hole. So, again, when I come back in a few years, and I meet you again here in Cyprus, and I ask you, have you seen cats with primary hyperaldosteronism? Then I suppose that most of you will say yes. Thank you very much for your attention.